Case Report. Three-dimensional regenerative ambulatory phlebotherapy for incontinent perforating veins in patients who have already undergone multiple phlebectomies. This patient had undergone bilateral saphenectomy of the great saphenous vein and multiple posterior phlebectomies in both calves. In the treated areas, new varices had formed owing to the persistence of perforating veins in the regions involved. Incontinent veins had been inadequately treated by phlebectomy, which, as is known, has a mainly two-dimensional action. Incontinent perforating veins had given rise to new evident venous ectasias. We viewed the sites of venous reflux by means of a spectroscopic analysis method. During the analysis, significant venous reflux was seen in the perforating veins of Cockett, Sherman and Boyd in the left leg. In the right leg, the perforating veins of Sherman and Boyd were seen to be incontinent and bulging. Numerous posterior bilateral perforating veins were seen to be feeding large varices with significant reflux. We performed three-dimensional regenerative ambulatory phlebotherapy, TRAP, which strengthens the vessel walls and narrows the veins until the calibre and consistency of a normal vessel is achieved. In this procedure, the patient lies prone on the table. The skin is disinfected with polyvinylpyrrolidone iodine solution, betadine, as its dark color accentuates the in-depth infrared imaging. Perforating veins giving rise to copious reflux are clearly visible in the sural region. TRAP is the new regenerative cure for varicose veins. Created by the plastic surgeon Sergio Capurro, TRAP induces the activation of controlled deposition of fibrous tissue in the walls of the injected incontinent veins. A sclerosing solution of sodium salicylate in a buffered hydroglycerine vehicle, diluted to a non-obliterative concentration, is injected three-dimensionally into those veins of the superficial circulation which are sites of reflux. Even the smallest perforating veins identified by means of the reflection-absorption technique must be injected. After the regenerative treatment of the walls of the perforating and superficial vessels, prolonged use of elastic stockings or bandages and normal physical activity are indispensable. We reiterate the fact that this patient had previously undergone phlebectomies in an attempt to resolve his phlebological pathology. The scars from the previous operations are clearly visible in the posteromedial region of the calves. Recurring venous swellings of considerable size are present, supplied by several perforating sural veins. TRAP treats the incontinent perforating veins that cause venous reflux pathology. Phlebotherapy narrows the calibre and strengthens the walls of the bulging perforating veins and induces anatomofunctional restoration of the venous circulation. During three-dimensional regenerative ambulatory phlebotherapy, the reaction of the injected vein wall is immediately visible. The reflection and absorption of infrared light shows the rarefaction of the veins and the loss of linear continuity of the walls. To inject the regenerative solution, we use a large syringe. The large diameter of the syringe reduces the compression force that the solution applies on the reflux in the treated communicating veins, and seems to us to be suitable for treating large veins with extensive venous reflux. The lower pressure of injection, which is due to the larger diameter of the syringe, reduces the dynamic turbulence at the confluence of the two fluids, the venous reflux blood and the therapeutic solution. The sodium salicylate solution in a buffered hydroglycerin vehicle is thus able to act with greater homogeneity on the entire ectatic vein wall. The viscosity of the solution helps to achieve this effect. Moving down towards the lower sural region, we come across refluxed perforating veins under greater reflux pressure. The possibility of effective day surgery treatment is an enormous advantage for the patient. After the therapy, the patient is able to walk, indeed must walk, as this allows muscle tone to be recovered in the lower legs in the regions immediately surrounding the dilated perforating veins. Where large incontinent perforating veins are present, the muscular fasciae bulge and are clearly visible on echo-Doppler imaging, transillumination, or better still, under spectroscopic analysis with invisible infrared light at a wavelength of 740 nanometers projected onto the patient's skin. The lack of homogeneity in the continuity of the fasciae is often evident on palpation. This patient is an amateur cyclist and regained venous anatomo-functional integrity in the space of 3 months with 3 sessions of bilateral trap, concentrated, in accordance with the patient's wishes, exclusively on the venous ectasias of the calves and the more frequent sites of venous insufficiency in the medial region of the lower leg. The treatment aims to restore functional muscular activity and improve performance in aerobic activity. It is always carried out with the aid of stockings with a pressure of 40 millimeters of mercury at the ankles. This patient has momentarily postponed treatment of the whole superficial and perforating circulation, which is required by phlebotherapy to make all the visible vessels disappear, preferring to quickly resolve the subjective symptoms in the sural muscular regions, cramp-like pains in the evening and after prolonged physical effort.